So let us make the great beginning, doctor, of the today's session. Megaloblastic anemia, that is not synonymous with macrocytic anemia, because macrocytosis can also occur without megaloblastosis. Non-megaloblastic macrocytic anemia, what are the causes is a favorite question of the examiner. So folate deficiency, vitamin B12 deficiency, alcohol abuse, hypothyroidism, liver disease, myelodysplasias, folate deficiency, any of them typically can lead to development of macrocytosis. Only when it is because of folate deficiency or vitamin B12 deficiency, it will also be megaloblastic. But if it is due to alcohol abuse or liver disease or hypothyroidism, it will be typically non-megaloblastic macrocytic. Right, doc? Now comes an important question. What is that mean corpuscular volume, which is the benchmark for you to call that it is a macrocytic cell? 100 is the number you need to remember. The moment MCV, mean corpuscular volume, is more than 100, you basically call it as the macrocytic picture is what need to be basically remembered. Now let us talk about folate deficiency. Fundamentally, what is the need of folate? For the synthesis of DNA we require folate. So anemia because of the impaired DNA synthesis is the underlying cause, which can be treated by giving the oral folate. So what is the bottleneck, doctor? Mean corpuscular volume is the bottleneck. It is the defining benchmark for you to call whether it is microcytic or a macrocytic anemia is what need to be remembered. So as a general physician, how will you approach the problem of anemia based on the peripheral smear reporting MCV, based on MCV, micro and macro? So whenever a patient has anemia, if he has got microcytic anemia, there are three important causes that bother you. Iron deficiency, most common cause, thalassemia, rarer cause, and possibly a sideroblastic anemia, which is also a microcytic anemia. Whenever it is macrocytic, lot of times it is your vegetarian patients who only eat vegetarian food, not even drink milk in some communities, who are considered to be orthodox vegetarians. Vitamin B12 is very common to discover in them. Then without vitamin, still what are the causes of macrocytic? Myelodysplastic syndromes, very important condition, doctor. I will tell you. A 48-year-old individual comes with the presentation of megaloblastic anemia. What will you generally think? It may be due to anemia, may be due to vitamin B12 or folate deficiency, and you will treat by giving multivitamins, right? But after few days, once more he presents with anemia. So typically, whenever you have a patient who has got a refractory megaloblastic anemia, in spite of treatment, once more megaloblastic anemia occurring repeatedly, that's an indication for bone marrow biopsy, where you discover the presence of a myelodysplastic syndrome is what you need to basically remember. So what is myelodysplasia? Just like cervical cancer has a cervical dysplasia, esophageal dysplasia precedes the esophageal cancer. So bone marrow will also say, no, before I become a cancer, I want to be something before that. What is that before that? Precancerous state, myelodysplasia. Lot of students confuse between myelofibrosis and myelodysplasia, they are different. Myelofibrosis means, suppose you are having, let us say, malignancy, some internal malignancy. That malignancy has gone and metastasized to the bone marrow. Then what will it do? It will initiate fibrosis in the bone marrow. That's called myelocytic anemia. So that myelofibrosis is different from myelodysplasia. Myelodysplasia is a precancerous state before a chronic myeloid leukemia or a myeloid leukemia develops, is what you need to basically remember, doctor. Now ethanol and liver disease, there are the other important causes for non-megaloblastic but macrocytic anemia. Already we discussed that. Even hypothyroidism, don't forget to evaluate in a patient who has got a megaloblastic picture, macrocytic picture. If the MCV is normal, then what's the problem? Maybe the bone marrow is unable to produce RBCs. So a myelodysplastic syndrome can even present like a normochromic normocytic anemia, any solid tumor, or if there is any myeloma or aplastic anemia. Whenever the bone marrow fails, the kind of anemia which you get is, once more, normochromic normocytic anemia. Right, doctor? Recently we discussed aplastic anemia in the last class, last Friday. I hope you still remember. In that, what did we say? Whenever you take a peripheral smear, you don't find any abnormal cells in peripheral smear for you to call it as aplastic anemia. Why? Because if there are any abnormal cells, means you should think of conditions like myelodysplastic syndromes, or where megaloblasts will be found, or myelofibrosis due to which bone marrow can fail, where teardrop cells will occur due to extramedullary hematopoiesis in the spleen. Without any abnormal cells in the peripheral smear, then you consider it as a aplastic anemia. So that's very, very important. Then some systemic diseases like liver disease, renal disease, because erythropoietin production doesn't occur. Then whenever there is any inflammation, even in that situation also, the inflammatory mediators will suppress the erythropoietic potential of the bone marrow, and that can lead to development of a normocytic normochromic anemia, is what you have to ultimately remember, doctor. So summarize, what are the risk factors? Alcoholism, a diet which is low in folic acid, causes of the megaloblastic anemia. Pregnancy also is a predisposing factor. Any malabsorption syndrome. So how will they ultimately present, doctor? With macrocytic anemia, glossitis, cheilosis, angular cheilosis, diarrhea can be a presenting feature, and what you see in the blood smear, macrocytes, basophilic stippling, very, very important finding. Nowadays All India MD entrance, postgraduate medical exam, is a online exam. So don't think examiner will leave you only with ECGs. Peripheral smears can be given in the exam, like USMLE. So you must be sure what is the meaning of hypersegmented neutrophils, how to recognize a basophilic stippling. Better get MD seat this year only. As the time passes, you are supposed to know too many practical things, and very difficult in MBBS to know too many practical things. Right? So hypersegmented neutrophils, where do you find, is a very important question. Presently our capability is only the English two words, hypersegmented neutrophils. Forget about how it looks like really in the peripheral smear. You need to do MD pathology to know that. If that is there in the MCQ, you will answer like a parrot, megaloblastic anemia. But really in your own blood smear, if hypersegmented neutrophil is there, you can't recognize. But still you can be a topper in MD entrance. That is not going to happen in future, because it's an online exam. It's very easy to give any slide. Then a low reticulocyte count is another important thing in megaloblastic anemia. So summarize, what are the non-megaloblastic macrocytic anemias, doctor? Hypothyroidism, myelodysplastic syndromes, sideroblastic anemia, liver disorders, etc., where you can find the presence of macrocytes which are not megaloblastic. Now let us talk about these two entities. Vitamin B12 deficiency, vitamin B12 deficiency anemia. But lot of times it is thought by people that it is synonymous with pernicious anemia. No, pernicious anemia is one of the causes for the development of vitamin B12 deficiency. Vitamin B12 deficiency can occur due to decreased intake also, that is not pernicious anemia. When there are autoantibodies against the parietal cells, because of which intrinsic factor production become diminished, that will interfere with the vitamin B12 absorption. In that scenario, you call it as pernicious anemia, is what need to be remembered. Any vegan diet, Diphyllobothrum latum, which is the fish tapeworm, and any ileal resection, because terminal ileum is the place where vitamin B12 absorption occur. Any bacterial overgrowth or celiac sprue like malabsorption disorders, there is a development of vitamin B12 deficiency. So how will a patient of vitamin B12 deficiency typically present, doctor? If you see one patient, you will not forget. Patient will say, doctor, I'm absolutely alright, I'm talking and there was a party in our home, all of us are sitting on the dining table, oh I'm very happy, my daughter returned from United States of America. Then my daughter said, please go Papa, wash your hand and your face and come back, dinner is served. So this gentleman has gone to the wash basin, he is alright, he has no imbalance. The moment he closed the eye to splash the water on the face, he fell down. What is the reason? Basically our balance, which is controlled by cerebellum, cerebellum can control the balance due to two reasons, two inputs. One input comes from our vision, second input is brought by our dorsal columns, gracilis, facialis and cuneatus, right? So even if dorsal columns are demyelinated in vitamin B12 deficiency, still the vision will enable cerebellum to control the balance. The moment the guy to splash water onto the face closes the eyes, neither the dorsal columns are bringing him info because he has megaloblastic anemia, subacute combined degeneration of spinal cord, and his vision is also not giving info to cerebellum, hence he will lose the balance. What is that called? Wash basin phenomena is what you typically see in a patient who is having the vitamin B12 deficiency. So Pernicious, a positive Romberg, but when will this Romberg will appear? What is the difference between cerebellar Romberg and a Romberg due to the subacute combined degeneration of spinal cord? When the eyes are open, Romberg doesn't appear. When the eyes are asked to be closed, Romberg appear. That is imbalance on tandem walking is Romberg, right? So that is an indication of vitamin B12 deficiency. Whether eyes are open or not, still patient has an imbalance, means that is cerebellar dysfunction. So he is what you need to appreciate. So the touch and temperature sensitivity are impaired, ataxia will occur, ultimately dementia will develop. Patient will not remember. One of the important reversible causes of dementia in this subcontinent called India is vitamin B12 deficiency. Because a lot of our patients are orthodox. They believe they are born, they believe they die in the same trust, faith that they have. So the faith and belief begins where the reason ends. So there is no reasoning for if you ask why will you not drink milk, why will you not eat chicken, if you ask the patient, he is born with the trust and faith and he will die one day with the same trust, but the cause should not be vitamin B12 deficiency because you are the doctor who is treating him, right? So dementia. But if the vitamin B12 deficiency is less than 6 months duration, the beautiful part of the story is if you diagnose and replenish vitamin B12, nicely patient will remember everything, is what you need to remember. Then glossitis, atrophy of the lingual papillae, etc., etc. Now doctor, What is the role of vitamin B12 in the DNA synthesis is a very important issue. Already we have reviewed it in our biochemistry class. Fundamentally, for the formation of the dump, uridyl monophosphate, which is important for the synthesis of the thymidylate monophosphate, you require the DNA for the DNA synthesis, the nucleotide synthesis, the vitamin B12 and folate. That's the reason the deficiency, what will happen? Nucleus doesn't mature because of the absence of DNA, but cytoplasm matures. So the cell contains predominantly abundance of cytoplasm with scarcity of nuclear content. So nuclear cytoplasmic dissociation defines the megaloblast is what you need to basically remember. So macrocytosis, basophilic stippling, hypersegmented neutrophils, low retic count and decreased plasma cobalamin defines the clinical picture of vitamin B12 deficiency. Now pernicious anemia, what is this? In this there are antibodies against the parietal cell. Parietal cell is important for two reasons. Parietal cell leads to HCl production, parietal cell produces intrinsic factor. So a chlorohydria will be there in these patients. Intrinsic factor deficiency will be there. If there is no intrinsic factor, basically whenever we consume vitamin B12, what will happen? There are a lot of factors called as R factors which are produced in our saliva, which will bind with vitamin B12. So this R factor vitamin B12 in a bound state will go up to terminal ileum. Intrinsic factor is produced by parietal cells. It will also go to the terminal ileum. Then somebody is required to separate the vitamin B12 from the R factor. Then only vitamin B12 can bind with intrinsic factor and get absorbed in the terminal ileum. Who is that separates the vitamin B12 from the R factor, doctor? Pancreatic proteases. That is the reason in the pancreatic insufficiency, where the proteases are not adequate, though vitamin B12 is there, intrinsic factor is there, still they can't bind because already R factor bound. By the time intrinsic factor discovered vitamin B12 is already married. So unless somebody can separate the two, then only intrinsic factor can bind, is what you need to basically remember. So it being an autoimmune disorder, there are antibodies even against the melanocytes. That's the reason patients will develop vitiligo in pernicious anemia as an associated finding. So how do you discover? We use a Schilling's test, but Schilling is almost outdated. Modern time, if you say Schilling, you are still in those British era. So doctor, but some rare questions in old question banks talk a lot about Schilling test. We will bother about it later. But how will you evaluate, doctor, suspected vitamin B12 deficiency? Best thing is get a serum vitamin B12 level. But lot of times what will we do? Anemia means eagerly everybody will give multivitamin tablets to the patient. So serum vitamin B12 levels can get altered because of that. That's the reason before you take a decision to replenish nutritional factor vitamin B12, get a serum and send it for vitamin B12 and folate levels. Now doctor, what are those levels you are looking for? Whenever it is less than 100 picograms, you call it as a definite case of vitamin B12 deficiency, no second thought. If it is more than 400 picograms per ml, then you call it as no vitamin B12 deficiency, and 100 to 400 is called as borderline between the two. Whenever you have borderline levels of vitamin B12, still is there any parameter which you can evaluate? If it is abnormal, then you consider vitamin B12 deficiency. Yes sir, methylmalonic aciduria, the levels of methylmalonic acid in the urine. Typically, though the vitamin B12 levels are above 100 but below 400, still methylmalonic acid levels will elevate, which is much more sensitive to confirm that there is vitamin B12 deficiency, is what need to be remembered. Now we were talking about Schilling's test, right? So what does Schilling test basically do? Eating of vitamin B12 only, is it problematic? Intrinsic factor production, is it problematic? Even though both of them are there, is there any small bubble, may lot of bacterial overgrowth which is destroying the whatever the vitamin B12 it is using, bacteria are using to live rather than human being. So at which level you will basically do, but really questions are no more asked about Schilling's test. So doctor, we said peripheral smear is very important. This is the typical megaloblastoid picture. This is a neutrophil with a lot of segments called nuclear hypersegmentation, which is a very sensitive and a very specific marker. Even if one hypersegmented neutrophil is there also in peripheral smear, your diagnosis is vitamin B12 deficiency and megaloblastic anemia is what need to be remembered. So these are the examples of other important findings. These are called Howell-Jolly bodies. Howell-Jolly bodies, basically they are seen in the case of the hyposplenism. Whenever the spleen doesn't function, normal function of spleen is what? Culling and removing the old cells. So Howell-Jolly bodies, this body, that body, you are able to see? So that is very important. Then this is called basophilic stippling, which is once more an indicator of vitamin B12 deficiency, and these are called Cabot's rings are the other important findings. So the hypersegmented neutrophil, doctor, a very sensitive and specific marker of the vitamin B12 deficiency. The glossitis is a very important clinical manifestation. Then this is the normal cell, nucleus versus cytoplasm. There is megaloblastic picture, means more cytoplasm, less amount of nucleus, becomes megaloblastic picture. That's all the background story, doctor. Now let us look at some of the common clinical pearls. Can you please check Naina and Harika, they have a small issue with the broadcast. Any local problem for them or global problem for everyone? Now doctor, typically in the exam, the favorite MCQ of the examiner is a 45-year-old male who is HIV positive, who is on antiretroviral therapy, develops macrocytosis. Who is the culprit? It is the zidovudine. Zidovudine basically lead to development of macrocytosis. Then what is a very important differentiator between vitamin B12 deficiency and folate? Folate only causes anemia. It does not lead to any neurological manifestations. Vitamin B12 causes both of them, right? Causes both of them. So that is the reason. What is the main worry about this finding? Suppose somebody had megaloblastic anemia. You thought it is due to folate and only treated with folate. Then what will happen? Anemia resolves. It doesn't resolve. It will progress because it is due to not folate deficiency but because of vitamin B12 deficiency. So vitamin B, V for vegan, I for ileal resection, T for tapeworm, and etc. etc. Nitrous oxide can cause vitamin B12 deficiency, don't forget. One of the favorite questions of the examiner. So what are you going to tell your anesthesia technician? You tell nitrous oxide is deficient, go and sue the chief, because if he is being found with vitamin B12 deficiency, I mean megaloblastic anemia. I still remember our anesthesia chief summoning me for having had written, really also when I was in MD. MD means all academic curiosity will be very high. So a patient who is an anesthesia technician, he came and found to have high MCV. Anesthesia technician was Krishnamachari. So I said, do they use nitrous oxide in your operation theatre? Yes sir. Oh, then I wrote nitrous oxide deficiency. Nitrous oxide is the underlying culprit. Anesthesia chief summoned, come to my room, I am ready with the belt. So what do you think, man? If you write nitrous oxide is responsible, what is the proof you are having? He is Krishnamachari, who does not drink even milk also. So that is the underlying cause, not the nitrous oxide. We are all inhaling the same nitrous oxide. If you write this and patient gets an idea of suing me, so who will pay? Will you pay? So that's the thing. But a favorite MCQ of the examiner, nitrous oxide, then bacterial overgrowth, then anemia precedes neurological symptoms, not neurological symptoms precede anemia in case of vitamin B12 deficiency. Then one of the important side effects if you are replenishing vitamin B12, another common question in the exam, hypokalemia develops in the patients. Why? If you are replenishing vitamin B12, cells are proliferating. Potassium is what? Predominantly intracellular ion. So that is the reason the newborn cells will all take up the potassium and that lead to development of hypokalemia. Then after you start treatment, when will reticulocytosis basically will develop? In peripheral smear is a common question. After 72 hours, that is on 4th day, is what need to be remembered. Is pernicious anemia is precancerous? Yes sir. There is an increased risk of developing the gastric cancer is what need to be remembered. Then what are the causes of normocytic normochromic anemia, doctor? Any bone marrow problem like myelodysplasias, aplastic anemia, anemia of chronic disease, or even if the iron and vitamin B12 deficiency in the early stages will be normocytic normochromic only in the early stages. Serum vitamin B12 level, what is the benchmark value? You need to remember 100 picograms per ml is what you need to remember. Then vitamin B12 absorption. I am trying to summarize some of the important things which we already had reviewed. Cobalamin binding proteins are called as the R factors. They basically compete with the intrinsic factor to bind with the vitamin B12. So who separates them in the terminal ileum? It is the pancreatic protease which is responsible. Ultimately the vitamin B12 which is being transferred from the gut through plasma, where will it go? To liver, and it will be stored in the liver. The vitamin B12 is what need to be remembered. Now comes a very important question, doctor. Who transports the vitamin B12 from the intestine to the liver? We have transcobalamins. In that you have 3 numbers, transcobalamin 1, 2 and 3. Who secretes transcobalamin is a very important question. It is a WBCs. Why is this fact important? Any myeloproliferative state like polycythemia, rubra vera and CML, in all these conditions what will happen? WBCs are proliferating. More WBCs will produce more transcobalamin absorbs more vitamin B12, hence vitamin B12 level elevation is one of the important marker which you see whenever there is any myeloproliferative state, because transcobalamins are produced by the WBCs is what you need to ultimately remember. Then out of all this, around 90% of the plasma vitamin B12 will be binding to these transcobalamins. Which transcobalamin is capable of transporting the vitamin B12 into the cell, say RBC? It is a transcobalamin 2 is very, very important. How much liver will store? Around 2000 to 5000 micrograms of vitamin B12 is stored. That is the reason if you don't drink milk for at least 2-3 months, you won't develop vitamin B12 deficiency. At least a malabsorption or a decreased intake of vitamin B12 for about 3 years is required. Until then the liver can be able to basically compensate. Then why abdominal surgeries can predispose to the development of vitamin B12 deficiency, doctor? There is a blind loop syndrome, as all of you know very well. In this, the bacteria which are overgrowing in the lumen of the intestine will be competing to use the vitamin B12 instead of giving it to the human body. Any surgical resection of ileum for any ileitis and inflammatory bowel disease will lead to development of vitamin B12 deficiency. Pancreatic insufficiency can cause, Crohn's disease can cause, etc., etc. Now, in the nervous system, whenever vitamin B12 effects appear, neurological features, why you call subacute combined degeneration? What is combined? One degeneration is peripheral nerves, there is a demyelination. Second degeneration involves the dorsal columns and pyramidal tract, right? So both spinal cord is involved and also peripheral nerves are also involved. But pyramidal tract is a part of UMN or LMN? UMN. So that is the reason, because of the pyramidal tract demyelination you get UMN features. Due to peripheral nerve degeneration you get LMN features. There are very few conditions where both UMN and also LMN features are found. One is vitamin B12 deficiency, Friedreich's ataxia is another important entity, motor neuron disease. In the upper limbs you have LMN feature, lower limbs you have a UMN features. In case of the motor neuron disease, you should basically remember. So first to get involved are peripheral nerves, next to get involved are posterior columns, ultimately the cerebral function also get affected and that lead to development of dementia. So what is the important characteristic finding, doctor, in the peripheral sphere? Macroovalocyte, hypersegmented neutrophils are the two important types of cells you need to remember. Then if you do bone marrow in vitamin B12 deficiency, what will you see and what do you expect? Basically what will bone marrow will do? Whenever there is anemia, it will try to compensate by increased proliferation. So there is a marked erythroid hyperplasia will be present. But what will happen? There is a ineffective erythropoiesis. Even before those young RBCs produced by the bone marrow leave the bone marrow, they are being slaughtered mercilessly within the bone marrow is what you need to basically remember. You will also appreciate those megaloblastic changes due to the asynchronous maturation of the nucleus and cytoplasm. That is, cytoplasmic maturation continues while the nuclear maturation does not happen, is another important feature in the bone marrow which you can appreciate. Then giant metamyelocytes in the bone marrow is another important finding in case of megaloblastic anemia. Then there are two important indicators in vitamin B12 deficiency patients that there is a ineffective erythropoiesis and intramedullary destruction of those young RBCs which are trying to jump into the blood from bone marrow. What are those indications? Whenever hemolysis is there, there is a release of the LDH, elevated LDH levels. Similarly, a modest increase in the indirect bilirubin. These are the two associated findings. High LDH is a feature in case of the vitamin B12 deficiency. So what are the normal vitamin B12 levels, doctor? More than 240. The moment it is less than 170, you start calling it as deficiency. Less than 100 means symptomatic deficiency, and between 170 to 240 is considered to be borderline. And if it is in a borderline state, even methylmalonic acid levels elevation is a sensitive indicator that there is a vitamin B12 deficiency. So ultimately, how will you treat, doctor? Historical treatment of vitamin B12 deficiency the moment you diagnosed. Very simple. 100 microgram vitamin B12 injection will be available. One injection every day for 1 week. After that, one injection every week for 1 month. After that, one injection every month lifelong. Is a standard prescription of the vitamin B12 injection is what need to be remembered. And once you give vitamin B12 injection, you expect reticulocytosis very brisk within 5 to 7 days. And if the CNS degeneration is of a short term, less than 6 months, then there is a very good recovery because it is a reversible dementia is what need to be remembered. Now, it takes 3 years for the vitamin B12 deficiency to appear because of the liver storage. How about that in folate deficiency? In folate deficiency, 2 to 3 months non-intake of folate adequately is sufficient to lead to development of folate deficiency. It is not that long as in vitamin B12. And how do you treat? 1 milligram per day orally. Folate is considered to be the way you treat the folate deficiency. That is all the story, doctor, about megaloblastic anemia, which you need to be very, very sure about.